It's my pleasure to open the session to discuss the current Ebola situation in Uganda. My name is David Hamer. I'm the interim director of the Boston University Center for Emerging Infectious Disease Policy and Research. And it's my pleasure to have with me two guests. One of them is Dr. Sira Madad, who's the Senior Director of the System-Wide Special Pathogens Program for the New York City Health and Hospitals, a very experienced infectious disease epidemiologist. And then Dr. Rogers Ayabari from the Infectious Disease Institute at Makerere University in Kampala, Uganda. And he is an infectious disease clinician and scientist. So I'm going to start with just a few general questions about sort of, Ebola and what's happening in Uganda. So maybe Dr. Ayabari, if you could begin with telling us just a little bit about the virus and the disease, and in particular, what strain has been identified in Uganda and what's happening with the outbreak there.
Thank you so much, David. It's a great opportunity to be here. Ebola virus disease is a syndrome caused by infection with one of the many Ebola viruses. And I think over the last 10 years, we've recorded a number of pilovirus or Ebola virus outbreaks in Central Africa, mainly caused by the Zaire species of the Ebola virus. So the disease caused by infection with this virus is what we've historically known as a viral hemorrhagic fever, due to the disease usually manifesting with bleeding in the later stages of the disease. But with what we've learned over the last 10 years, this is a virus that causes an overwhelming immune reaction in the body that we call sepsis, which basically mimics a number of other infectious disease processes caused by other pathogens like malaria and other drug-resistant bacteria. So this disease is quite fatal. Current estimates from infection with the Ebola virus range anywhere between 45 and 90%. And although we have studied a lot in the last 10 years, and we have two effective therapies for one of the Ebola viruses, the Sudan Ebola virus, which is causing the current outbreak in Uganda, we do not have any licensed therapeutics or vaccine. So it's a case for urgent consideration to be able to study as much as we can and prevent further spread. Thanks.
So just one quick follow-up question. You mentioned that the Sudan strain is responsible for the current outbreak, and this is, substantially different from the DRC strains that have caused prior outbreaks in the DRC, and then in West Africa and Liberia, Guinea, and Sierra Leone. Do we know a lot about this strain? I mean, is it similar in terms of pathogenicity and potential case fatality rate to other strains?
Sarah, would you like to take that?
Yeah, okay. No, absolutely. So, a couple of things that I'll mention with the current outbreak of the Sudan virus. So this is the fifth Ebola virus disease outbreak of the Sudan virus that's been reported in Uganda since 2000. And there's been multiple different outbreaks of this particular species of the Sudan virus, but majority of the outbreaks of Ebola have been of the Zaire species. And so our current knowledge is mainly from the Zaire species. But obviously in this current outbreak and in the prior ones, there's information that can be gleaned from it. The case fatality is different. So as we know about Ebola virus disease, it's basically there's 4 viruses within the genus of Ebola virus that can cause infection in humans. and Sudan virus is one of them, which has a case fatality of a little bit over 50%. If we look at the prior outbreaks of Sudan Ebola virus, they have ranged from 41 to 100%. But right now, in the current outbreak that we're seeing, it's hovering a little over 50%. But if you compare it to some of the other species of Ebola virus, like Zaire is the most common one, that has a case fatality of anywhere from 70 to 90%. And then some of the other ones are a little bit lower. So in terms of case fatality, luckily it is lower, but as just mentioned, there is no for example, when we talk about the United States, as well as, what's available in the continent of Africa, there is no approved vaccine for the Sudan virus. There's no cross protection against the one we have for Zaire. So that certainly is concerning, but luckily there are 2 vaccine candidates for the Sudan Ebola virus that's being in discussion right now. And we'll see, hopefully, if trials of that experimental vaccine will start in Uganda. Just in terms of treatment, the one thing that I'll mention, there is obviously, there's also no FDA licensed treatment for the Sudan virus, but there is a monoclonal antibody that looks quite promising. So, unclear of what the supply of that kind of looks like, and, how soon that could potentially even be started in Uganda.
Great, thank you. That was very helpful. So interesting. Sadly, we'll learn more about this strain, I think, during this outbreak.
The one thing that I'll also mention is the last time there was an outbreak of the Sudan Ebola virus was about 10 years ago. So, there are outbreaks, as I mentioned, but they've been pretty far in timeline. So it's not as if it's been one after another in their shortened number of years. It's actually the last time was about 10 years ago. So it's concerning to see it obviously emerge right now.
Mm-hmm. And presumably this is starting as a spillover from some sort of natural reservoir.
That's, love to hear what others think as well. But from my understanding, in terms of how this outbreak may have started, it seems as if the initial index case, presented to, a healthcare facility and was, diagnosed with Ebola virus disease, and the next day it was speciated to be the Sudan virus. But even by then, based on what the CDC has shared, it seems as if there's already potentially community transmission and nosocomial transmission occurring within that facility as well. And so by the time this initial index case was detected and confirmed to have Ebola virus, there was about, perhaps a 3 to 4 week period where there may have been community transmission and potentially nosocomial transmission occurring. And so there's more information that's obviously being learned day by day. I think personally, as I try to look at the case number that we'll share with in this presentation, I think the case numbers are very hard to come by first. I think it's also a very fluid situation, but perhaps Dr. Urabe can talk a little bit about the case numbers. I can certainly share, what the numbers I have, but I'm not sure if it's the latest ones that you may have as well.
Well, why don't we, Rogers, why don't you maybe tell us what's known, at least in Uganda, both in terms of numbers, as good as they are, because they may not be that accurate, and I'm sure it's a moving target, but also, what part of the country's involved and how widespread this is geographically.
Oh, sure. So the epicenter is in central Uganda, in the district of Mubende, which is, I would say, precisely midway between the capital Kampala and the western border of Uganda towards DRC. And as of yesterday, we had the Ministry of Health had recorded 48 cases, of which 17 had unfortunately succumbed, and about 31 were in active admission. There are a number of patients under investigation in multiple locations around the city, and the Ministry of Health is trying to rev up on the lab testing capacity so that those can be quickly ruled in or ruled out. But indeed, the lab diagnostics, especially the lack of portable platforms like GeneXpert, which we've used for Ebola Zaire, has been a key bottleneck in actually rapidly assessing the scale of the outbreak.
Okay. But
Maybe
right
also,
now, go
sorry,
ahead.
yeah, I mean, geographical scope wise, so the Mubende, the first cases in Mubende resulted in two additional transmission chains in two neighboring districts on either side. And as of this week, that is October 12th to 14th, we also were able to pick two additional cases in the city Kampala, but these were still linked to the transmission chains back in central Uganda. So although we have indeed reported cases here, no local transmission has been reported in the city area, and we are still looking at transmission still linked to the primary cases in the Mubende area.
Well, that sort of raises an interesting question for me. I mean, one is, what is the approximate population of Kampala right now, and then what is the government doing? I mean, it sounds like you're doing, contact tracing of exposed people. Are there any other measures that are being put in place, either to restrict movement of people or to enhance awareness of healthcare providers to be watching for this, or any other measures from the public health standpoint? Maybe you can start, and then Sarah may know about this as well.
Oh, sure, thanks. So Kampala, which is the most populous area in Uganda, has a population of about 1.5 to 2 million people. But this is, the day population when people come to work, and we have a big suburb, which we call Kampala metropolitan area, and that could go even as high as 5 million people. Mm-hmm. So, that said, the current strategy is first of all to make sure that we have established treatment centers, which have been prepared to receive patients that have a diagnosis of Ebola Sudan virus disease. And the other strategy is to prepare all healthcare facilities within this huge area to ensure that they are actively doing screening of all people coming to enter the facilities, with special emphasis on healthcare workers. And then also all hospitals or health facilities which have inpatient services are also actively setting up patient under investigation holding areas. And one of the innovations we had from the COVID time was establishment of an emergency medical service. And this has also been leveraged to support movement of such patients from facilities with low capacity to bring them to places with high capacity or to definite treatment centers once they receive their diagnosis. So we are trying to build a wall of protection in the primary healthcare facilities, so that the bigger facilities, because the Kampala metropolitan area has about 5 national referral hospitals, so we are trying to protect those which actually serve a bigger demographic beyond just the Kampala metropolitan area.
Great, thank you. Well, that sounds reassuring, although at the same time worrisome. I mean, Kampala, especially if you look at the metropolitan Kampala, it's a lot of people, and if you end up with similar situations to what happened in Liberia, Guinea, and Sierra Leone, was sort of spread from rural and urban populations, and the risk becomes much more challenging to control this. Sarah, do you have any thoughts or comments on maybe the control aspect, both at the level of the country, but also regionally and beyond?
Yeah, so I think first, within Uganda, as mentioned, I think there's certainly a lot of effort, both with the Ministry of Health and the government in Uganda, as well as with international support. There is growing U.S. presence in Uganda to help support the response. And it's kind of the classic outbreak response of trying to box in the virus and make sure there's treatment facilities in place, the ability to do rigorous contact tracing. I think based on one of the latest reports I've seen, from a contact tracing standpoint, they have been able to contact. So there's about over 1,000 people that are on the list, and they've been able to contact about 90%, which is really great to hear in terms of trying to contain this epidemic. But in terms of the situation in Kampala, that it's something I think is a significant moment in the outbreak, as you've mentioned, David. It may be a catalyst for larger spread, but knowing that these two cases are not necessarily from community transmission happening in Kampala is a little reassuring. So as long as there's good contact tracing happening, I think that's certainly very key. The one thing that I'll mention, and I'll maybe pivot over to the domestic side, right? So outside of Uganda, when we look at the risk of international or regional spread of Ebola, right now the World Health Organization, along with the CDC, has put it as low in terms of regional and international spread. But as we know, the situation is fluid and can change. But there is a lot of preparedness happening domestically. For example, here in the United States right now, first there is exit screening happening in Kampala. So anybody that's coming over from Uganda, there is exit screening happening. And then there's entry screening happening here in the United States, as well as any passengers coming in from Uganda are being funneled through 5 US airports. And then there is entry screening that's happening here in the US. We don't have a whole lot of folks that usually come in per day. So it's about less than 150 people coming in, by flight from Uganda. And there's no direct flight as well. And so what's important is that we have multiple layers of intervention and mitigation here in the US. So obviously, having that screening in place could be helpful. But as we know, with the incubation period with, Ebola virus disease, and obviously we're dealing with the Sudan virus species, it could obviously be from 2 to 21 days. And so an individual could be asymptomatic and be traveling and then be symptomatic when they arrive here in the US. And as we know, the virus doesn't transmit when you're asymptomatic. So during the travel period, if an individual is asymptomatic, then there's generally no risk. They're not coming in contact, obviously, with the bodily fluids of this individual. But if they become symptomatic, the process here in the United States that has been stood up is that with these individuals coming in through these 5 US airports, the local health department or the state health department in that particular region is going to do active monitoring. So they'll have a list of all the passengers, and they'll evaluate these individuals if they become symptomatic and do an assessment and see if they're high risk or low risk. And then the local health department will be following up with these individuals for that 21-day duration at whatever interval they decide to do. And then if they do become symptomatic, and obviously this is obviously a low likelihood or low probability, but this is where you want to make sure you have a good process in place. So here in the US, we have 10 regional Ebola and special pathogen treatment centers across all US states and territories. And so there's 10 of them that's located, as well as other Ebola treatment centers. So there's 10 regional Ebola special pathogen treatment centers, and there's about 50 treatment centers, Ebola treatment centers in the US, is my understanding. And individuals that become symptomatic can go there for testing and treatment. And so there's a lot of work that's happening on the back end at the local level and at the facility level to ensure that there is a process in place. And the CDC has also done some additional measures. So they came out with a health alert just about a week or so ago that alerted the scientific and medical community that there's an outbreak of Ebola happening in Uganda. And if, as clinicians evaluate patients, make sure that you just take a thorough travel history and exposure history, looking at science and epidemiological risk factors if they're coming in from those 5 districts that are reporting cases of Ebola virus disease. So there is a lot of these, layered mitigation measures that are happening here domestically on the preparedness front. But the most important part is that we are doing all we can to support the government in Uganda to ensure that they can obviously support the individuals that are being infected, those that are exposed, and able to contain this epidemic before it grows even larger.
No, so I have a follow-up question, which is, you described very nicely what's happening really in Uganda, but also in the US, but a lot of flights out of Uganda either go through the Middle East or Europe to reach, for people to reach here. And what are there similar like screening or any activities going on in either airports or by countries on the routes that would lead people to the United States or Europe for that matter?
So I don't have the data in terms of what countries besides, for example, the US that have stood up this active monitoring program and screening. And as we know, these types of programs are they're not foolproof. They're not 100%, especially when we look at the incubation period of a virus. But this is where having that multiple layers is important. So here in the US, it's just one of the multiple different interventions that are in place. I'm not sure if other countries are implementing something similar.
Thank you. So I have, I guess, just one more question. I mean, I guess, first of all, I'd like to make a note to the audience that both Dr. Madad is a adjunct seed faculty, and then Dr. Ayabari is a adjunct seed scholar. So they're both associated with the BU Center for Emerging Infectious Disease Policy and Research. But I think maybe just to wrap up, if you could both maybe say a minute or two about, some key takeaway messages for the general public. And maybe you'll start with Dr. Ayabari.
Thank you so much. So some key takeaways for the public. I think for the context of the people who are in Uganda, is that the outbreak response is still gaining momentum. So we are still trying to find that one key ingredient that holds everything together, and that is trust. Because I think this outbreak is happening at a very critical time when we've just been still in conversations with the community regarding trust for COVID vaccine rollout. So we are still trying to see how we can leverage those connections and conversations to build trust, so that people or patients in the community who meet patient under investigation criteria, or who know people who are contacts in the community, they are able to at least to communicate to them, so that they can come in the established system for care and early containment. One of the big challenges we've experienced, or one of the big blows, is that significant number of the initial deaths were healthcare workers. And the challenge is that at this point, with the COVID, we had a bit dropped the ball on, the expectation for viral hemorrhagic fevers. So, I think with COVID vaccination, there was still a bit of relaxation in some of the strict infection control measures, but also the index of suspicion was quite low. So we are working hard to increase healthcare workers' perception, and the message to healthcare workers now is that focus on building your individual capacity, and that your safety is paramount, because healthcare workers are our our key tools or key pieces in putting on a successful response. So we are training healthcare workers for their safety, to ensure that they are both competent, technically and emotionally ready to support the response. And finally, although the Ebola virus is highly infectious, the situation is not out of hand. And even in a recent address by the president regarding the outbreak situation here, he did stress that the situation is not out of hand. And since this is the condition which doesn't have pre-symptomatic transmission like how we saw for COVID, then I think even some of our what I would call traditional public health epidemiological measures to controlling the disease will apply. So I think we just have the tools. We just have to bring the community on the table so that we can function properly.
Great, thank you very much. And Dr. Madad?
Yeah, so I'll tailor my message to specific audiences, and I'll obviously cater more to here in the United States, as I'm sure the US government and Americans obviously are looking and seeing what's happening, and it may be a little bit scary and fearful as you compare it to the COVID-19 pandemic and monkeypox and everything else. So I think first when we look at it from the general viewpoint of what is the risk, generally here in the United States, it is low, but as I mentioned earlier, things can change. But when we talk about just generally, for the general public, I think it's important that if you are going and traveling to any of those 5 districts that are reporting, active cases of Ebola virus disease, that you see the CDC website. They kind of let you know what's happening in certain parts of the country, and make sure that you're in contact with your healthcare provider, and just certainly make sure that you're being vigilant, depending on the activities that you're embarking or participating in. But generally the risk obviously is low, for importation here. But for healthcare providers in particular, I think it's important that healthcare facilities have, preparedness and readiness plans for Ebola, just like we do for any type of infectious disease. But they really do take a thorough travel and exposure and an epidemiological history and on every patient, and that really is important. But what's also important is to know that while the risk of Ebola is low, the more common causes may be malaria, and so not to delay treatment or testing for malaria. And we have resources like the local health department that you can turn to. So if a clinician does suspect, this patient may have Ebola, they should not be shy to call their local health department and have a consultation, with the epidemiologist on call at that local health department to walk through the case and see if this individual even meets the case definition for Ebola virus disease. And again, not to delay any additional treatment or testing, for example, for malaria, in consultation with your local health department. The last thing that I'll also mention, because this is a question that I often get when we talk about different types of infectious diseases, is that as mentioned, by Dr. Ayubari, that Ebola is a serious illness. It is often a fatal illness, in other parts of the world. This is where we really need to make sure that we're providing really good supportive care and any treatments that are available. But at the same time, it's also not an airborne virus, right? So when we talk about the transmission of Ebola virus disease, it's not something that's airborne. It's through contact of bodily fluids of an individual that's infected or that has recently died with, Ebola virus disease. And so just, looking at some of the ways of transmission, as well as looking at the risk level here domestically and certainly internationally, is just really important to put things into perspective. And our full attention should absolutely be to provide support to the government of Uganda and make sure they have everything that they need, both in terms of resources, both in terms of personnel and infrastructure, and all the logistic support and technical support that is needed.
Excellent. Thank you very much. And you actually raised a couple of things that I think are really important points. And, one of them is that clinicians everywhere need to take a travel history. Because if you don't do that, you can easily miss somebody that's importing an infection, whether it be Ebola or many other diseases. And that in the outbreak in West Africa, there were delays in treating people for malaria, and some of those were fatal. So I think it's important to not lose sight of things that may be even more common. So, but that's reassuring. I mean, honestly, my hope is that with international support, the Ugandan government, Ministry of Health and related partners are going to be able to control this fairly quickly. I think there's a capacity there to do it. And as long as the resources are there, it should not continue to grow if all goes well.
I definitely agree. And the one point that I'll also stress is it's really important to protect the workforce. And you're seeing obviously an increasing case count of healthcare workers getting infected in Uganda with, right now I think it's 10 or 11 healthcare workers infected and about 4 that have died. So just really important that we are doing everything we can to protect that workforce.
I agree with that.
Yeah, sure.
Rogers, you want to add a comment?
Yes, and I think maybe despite the unfortunate occurrence to our 4 healthcare workers, one of the most significant developments in this outbreak response is that the Ministry of Health has championed quick access to medical countermeasures for Sudan virus. So, at least for some of the cases that we've managed in the last 2 weeks, they have had access to at least 2 experimental therapeutics for Ebola virus, including remdesivir, which we at least had local experience with from the times of COVID-19. And also an experimental monoclonal antibody has also been made available through an expanded access program. So we believe, at least with these tools, that should give us a nice segue into any research or evaluation of these medical countermeasures. But also, I believe it will help us set a precedent on how the regulatory framework for encouraging access to expanded, access to investigational products will look like in future outbreaks. Okay.
Great, thank you very much. So I think we can wrap up here. This has been a fantastic discussion, very informative, and I appreciate both of you taking the time to join us, and particular Dr. Ayabari at so late at night in Uganda. But thanks for providing insight into the current Ebola outbreak.